अभी बस 2 मिनट है अभी।
कौन है?
सत्यजीत सिन्हा।
क्यों ऐसा व्याकुल हो रहा है?
अभी है ना 5:30 पर। हाँ।
अच्छा, बस I think we can make it live now. It's 1 minute only.
डिसाइड कर लो, ठीक है, कर लो।
Welcome once again to yet another webinar, and it is my proud privilege to introduce the speaker today, Professor Rohit Shetty, he's the Vice Chairman of Narayana Nethralaya Eye Institute. He's an affiliate associate professor and PhD guide at the Maastricht University in Netherlands. Dr. Shetty has over 150 publications in the peer-reviewed index journals, and he's corneal and refractive surgeon at Narayana Nethralaya Eye Institute, Bangalore, India. And his other works of interest include neuro-ophthalmology and electrophysiology. Dr. Rohit defended his PhD from the Maastricht University, Netherlands, on understanding the clinical, immunological, and genetic molecular mechanisms of keratoconus. He actually is so very well known to us as a clinician as well as a translational scientist. And he is a pioneer in using procedural treatment for dry eyes in India. He was probably one of the first ones to use both LipiView and LipiFlow, which he's been using for the last 9 years. And as I introduce him, we also have a duty to perform, and that is the launch of the guidelines which have been brought out from the All India Ophthalmic Societies on the procedural treatment of dry eye. And these are going to be available to all the AIOS members very soon. And this basically contains the pathophysiology of the Meibomian gland function, the diagnosis of the Meibomian gland disease, the techniques of Meibomian gland grading, the classification of the investigation tools in general clinic and the specialized unit, the evaluation of the newer technologies, particularly the LipiView and the LipiFlow, and section on special cases, which includes the contact lens wearers as well as the cataract surgery. It is going to be an important document to read and to educate yourself in the Meibomian gland, in the field of Meibomian gland disease. So with this, over to Dr. Rohit Shetty, who is going to be talking on the procedural treatment for dry eyes in India.
Thank you, ma'am. Thanks a lot. And thank you, sir. I'd like to thank AIOS for giving me this opportunity to share work on something which is very interesting because this is some question which keeps asking. I'm very happy that you and AIOS has come out with the guidelines because once we have a guidelines, it makes things much easier and simpler. My talk today is on procedural treatment of dry eye. Many things has already been covered by you in your book, which I think is going to be released to the members. I'm just going to cover up something which is very fundamental in understanding dry eye and also about the modern day treatment. So I'm going to narrow my talk today just to these few things. And after this, I will request all the people who have logged on to wait till the end because we have a live demonstration in the other room of us where we're going to show how this procedure of LipiFlow is done. These are my financial interests. I do receive grants from J&J, Carl Zeiss and other companies, but very clear that we were one of the first users of LipiFlow in the world. We got it 9 years back before J&J took over. So I don't have any direct financial interest into this product. One of the major questions asked by a lot of our colleagues during meetings is dry eye really hype or reality? Because it just started peaking up in the last few years. People do ask me that can dry eye be linked to just because there are more procedures available, or is it because there are more drops and medications available? So I divided my talk into these 4 topics, and I'll go into these 4 factors: what we know, what we don't know, what we should know, and what are the applications. And this not only applies to dry eye, virtually every aspect of medicine, because there are these are the 4 foundation to understand any disease or any procedure. Uh, this has been used very commonly about the whole Deuce classification, how it's expanding. It's increasing in its girth. It's actually becoming more and more bigger. It's becoming bigger because we are understanding more. And more new definitions have been added. And this is something which is of very big use for us is when you don't have signs and when you have symptoms. And this is probably what Meibomian gland dysfunction today is about, because all Meibomian gland dysfunctions don't have signs, but they come with a lot of symptoms. So subjective symptoms when patient comes to you, one of the most important thing for all of us is to understand the patient through questionnaire. It does not take much time. It's freely available. The OSDI is one of them. There are many other things which are available freely online. It's this, I use the OSDI because it's something easier and it's quicker. And we give this to our patients when they're waiting outside. So that when the patient comes in to your room, you already have a questionnaire filled and you know what score he is. Because it's impossible to ask all the questions to the patient and you exactly know where he stands in terms of symptoms are concerned. The second thing is what has really changed. Like I started my talk with asking a question, is it really an hype or is something in a reality? Or is something has really changed over the last decade? Because if I ask, say, Namrata ma'am or Rajesh Sinha sir about this at the end, they've been practicing this for long time. But the surge of all this new medicines, new technology has just started in the last decade, or little more than a decade. So what has really changed in this decade? So that's where the whole understanding is, we have to really look at the modern look at an ocular surface. The ocular surface, what we've been told or what we've been reading is a little outdated in today's context, because what we really know, 80s, 90s, 70s, we had a different level of food, the work was different, our bacteria was different, the ocular microbiome was completely different. And the dry eye used to come with a different kind of a picture. You used to have a Schirmer's or evaporative or aqueous deficient dry eye. And it used to come with a certain set of cytokines, which are the inflammatory mediators. You don't get dry eye, you don't get inflammation in your body, you don't get disease without cytokines or inflammation. Inflammation are the foundation for everything. Whether you have just a running nose or you have a rheumatoid, everything links to that. So, and it used to go off with certain drops. You give some drops, very mild steroids, and it would just go off. It would not take much of an effort. So nobody really bothered. But let's come to this past a decade. Everything started changing. Our food started changing. We spend more indoors with our ACs. Our work is different. We are working in an extremely non-conducive environment where you have humidity. A lot of these companies don't have a proper humidifiers. They don't have the AC is not of a proper optimal level. The particle count in that rooms are very high. So what is happening is, most important thing is our microbiome is changing. Bacteria controls everything, our body, our mind, the eyes, the gut, everything. So it's kingmaker. It's there, but you don't see it. And what's really happening is these things suddenly bring out a lot of changes in the pattern of dry eye, what we're seeing. You get pain without stain, you can neurodyna, allodyna, hyperalgesias. These were not something which would be what we would see when we were postgraduates. But the new generation of people, or all of us now, had to be extremely aware of these things. That you can come with especially like chronic pains. They would come with pain. They would absolutely, and we would diagnose as dry eye, but the Shermer's T-buds would still be normal. So what's happening is there are new set of molecules, a new set of cytokines which are just creeping in. These molecules are driven by different factors, and these molecules actually change the whole dimension. So in this graphics, what I'm going to show is the change in your food, change in your microbiome leads to inflammation, and these inflammation creates an altered microbiome and then cause diseases. And so these are all extremely new concepts which are coming in the picture of dry eye. And this is something which we should all know, because lubricants or just giving some steroid for 1 week, 2 weeks, it's just not going to help. We are just seeing the tip of the iceberg. As we keep moving, probably in the next decade, we'll see an explosion of these people with completely unanswered pathways. And because we just started, because what I just mentioned in this particular graphics, which involves all these things, including your AC, is one of the most important factor to change your ocular microbiome in your office work, and especially the change in your genetics. But this is what we know from this time being. So what we don't know is also very important, because this is something which I really like, this slide with somebody erasing something from your frontal cortex. What's important here is we all have certain beliefs, certain ideas which we have got from the time we were at the postgraduates, and we learned from our teachers, and the teachers learned from their teachers, and this become part and parcel of our DNA, and we assume that this is what the real truth is. In dry eye, I think it's time we start erasing some of those hardwired thought processes. It's time we look at it from a different aspects, because those processes are so tightly wound in a system. It just keeps getting back the same concept. For example, you have a dry eye, you should have something which is low. You should have tear secretion low. You should have more of dysfunctional glands. But that is not the case, because things have started changing. The first question, what we don't know is, why should only some percentage of them be symptomatic? And why should some people are totally asymptomatic? So that means you may have somebody with absolutely no tears in them. The Shermer's is low, so is their inflammation, but they have absolutely no pain. And some people have absolutely everything normal, but they complain of all the time some kind or the other kind of a problem. It's all lies in how your nerve impulses are connected. You have nerves, which is here, we have dendritic cells, healthy nerves. So healthy nerves makes eye to respond much less compared to something which is unhealthy. And what really makes them unhealthy is many factors. And this is one of the factors which we figured out, that there are a lot of different level of inflammatory molecules, and we linked it to vitamin D. Could be one of the factors, maybe multiple other things which may be linked, but just give me a link of how a small change. Why vitamin D deficiency? People are more indoors now. We work indoors. We close our windows with blinds. We hardly see sunlight. People hardly see sunrise or sunset. Both of them, they miss completely. So what happens is our environment gets changed, and these factors are the ones which could be probably triggering off. And you can see that these are all unhealthy nerves, and these unhealthy nerves are more symptomatic. And these are the patients sometimes, even with these unhealthy factors, they could have a high OSDI or a low OSDI. And that means that there are multiple permutation and combination how each person behaves. For example, the first question you have to answer is why some people behave differently than the others is because, again, it's your nerves, inflammation, and the most important factor is your genes. That means that genetically, if you are a kind of person where you are expressing more of pain, or sometimes how when you get hurt, or when somebody touches you forcefully, you start having more pain. That means that your nerves trigger off in a different way. So that is one of the reasons why two people with the same Shermers or the same T-bud don't behave the same way. It is because of how they are connected internally and also how they're connected to your nerves. And each one would have a different cytokine profile. So if you're looking at a low T-bud, decreased nerves, changes in your nerve factors, the keratocytes which are there gets activated, and all of them are linked to how the nerve starts firing. For example, these factors, what I just mentioned, this looks complicated. I understand that it takes a little time to understand all this, but however, it's very important for us as clinicians to understand, at least keep it somewhere in our cortex and understand that why some people behave differently to different stimuli, why some people get respond, why some people have absolutely no tears in them but they're just comfortable, why somebody has just around one drop in their tear component and they're just completely unhappy. It's just a matter of how everything is kind of spaced, including your genes in your practice. So what current diagnostics we have, they are the gold standards. The gold standards because it is quick, it gives you a quick understanding of what is happening. But the major challenge is, I like this cartoon a lot. I keep using it in many of my presentation. It's like you are using an extremely old concept to find a diseases which is completely new. That means that you still is a benchmark, still is a gold standard, but we have to keep finding out if we have something better, because that what you have is still not giving you that confirmatory diagnosis in your clinics. So that is something which is very important for us. So how do we know? What do you, at least something to measure? And that's where the whole component of Lipi flow comes, Lipi view comes. Lipi view is, it measures the tears, the lipid in your tears, it quantifies it, it uses an interferometry measurements, and you can see that a healthy tears has more colors, it's like oil on water, and unhealthy tears has no colors. And it's a very complex technology. I don't want to go into this, but machine makes it easy. So it gives you a very quick and very fast understanding of the quality of the tear film. So if I play this video here, so every time somebody blinks, this is what happens, but we don't see because it's not something which is seen. That the lots of colors gives you this value, which higher the value is always better, which means that's a healthy tear film. So if you look at the unhealthy tear film, every time there's a blink, there's absolutely no tears coming. There's no lipid layer. There's not, tears may be normal, but it's more of an evaporative status. So, and you can see that the quality of tear film is also very poor. There's one shot diagnosis which makes you understand that apart from your regular uh, T-buds and Shermers and staining, this tells you the state of lipid. It's very important because this classifies into different level of tear film changes. The second component is the importance of Meibomian glands and the gland loss itself. These are the images. Now the Lipi view also has as an meibography. Now meibography is becoming a standard of care both in refractive and cataract, and also a lot in contact lens practice. This is how it looks as dropouts. Both functionally and anatomically, this really complement to each other because you tell how is the status of the tear film and how is the status of the Meibomian glands, and very, very useful, especially in your refractive practice. But I'll play a devil's advocate here. This is very important. Let's look at two pictures. You look at a gland loss. There are machines today from IDRA which gives you the amount of gland loss also. So you have a gland loss of 50% and gland loss of 15%. If I ask you which one would be more symptomatic, it's a very logical answer is that the gland loss with 50% would be more symptomatic. He should be the one who should have a lot of problems compared to this gentleman out here who has a very small amount of gland loss. But the answer is completely wrong. This is what makes today's practice extremely confusing as far as dry eye concerned, because the gland loss of 50% does not make him less having a less OSDI or a high OSDI, or he has a very low T-BUD. It's completely opposite. That means, even though I'm just playing a devil's advocate here, even though there are different types of gland losses sometimes, it is just not the gland loss which makes a patient have symptoms or no symptoms. The multiple other factors which I'm going to go as we go further. So why does this happen? Because if I really look at, uh, again, going back to the devil's advocate here, are they really perfect? These machines, what we rely on? Because it's important, because this slide is very important, because this one of the fallacies of a myography is that it sometimes, if you have a lot of conjunctival edema, if you have a papillae, if you have a inflammation, the infrared light just doesn't go through it, and it comes as a complete dropout. You start the patient on steroid, or you start the patient on long-term treatment, once the inflammation comes down, the gland steadily starts appearing. There are papers on this which are completely misleading, which says that the glands reappear. Glands cannot reappear. Once you're dead, you're dead. So people using the mybography has to use it with a lot of caution, and use it in correlation to what you see after you invert the lids. It is not it's not some kind of a bypass to your clinical examination. It just gives a value to what you already know. So it just gives you. So if you feel that there are a lot of edema and other things, it's best not to rely on the mybography. So it just tells you one important thing is we don't have anything perfect yet. It's just a lot of variables, and one of the more variables was mybography and the lipid view, but they are still the best because it tells you something which you probably would never seen. So how do you understand this more? And there was this beautiful article in ophthalmology which speaks about the role of corneal nerves, and I did also speak in the beginning about how corneal nerves is important. This is a topic which is not something which is commonly touched upon, because confocal microscopy is not a standard of care in any pre-op evaluation. Even though it's commercially available, one of the best things to really see the in vivo function of the structures, but it's something which is more relegated to research use. However, I feel that this is of a great use if you have one, or hopefully when they become more commercially viable. As I would rather say, it's a business wise, it becomes a viable for them to make it in more numbers. So what happens is, this is how a confocal microscopy rip. This is from Heidelberg. What happens is, these are how the corneal nerves are. Perfectly healthy nerves with branching. They talk to each other, and a lot of these factors are there. These are unhealthy nerves. They are multiple branching, and these cells are your dendritic cells. They need to be in the periphery. They call Langerhans cells when they come into the center of the cornea, especially closer to the nerves. When they're very close to the nerves, and these are the patients who start having a lot of pain. So we did some study about how close they are to the nerves and the effect on this, because these cells sitting on the nerves irritate them a lot, and they are responsible for this chronic pain which will never go away. And this is also very important. These are microneuromas of the nerves, and these are the patients who have come with chronic neuropathic pain. They complain of pain, and just nothing can relieve them. You treat them with whatever. And one of the things which really I feel helps in them is probably uh, autologous serum, because there are some new nerve growth factors there, but still we are not sure how to treat them, because this is, without confocal, it's impossible to pick what is really happening. And these are different types of nerve parameters here, the loops, and you can see some microneuromas out here. And these are all huge dendritic cells out here. It's like starry sky appearance with all over the place. The OSDI, the ocular surface disease index, I call it as the poor man's confocal. The reason being, a lot of things what we are able to see on the confocal, we were able to pick it up, correlate very well with OSDI. So that means you don't need to buy a fancy confocal all the time. A good OSDI score, the higher the score, higher is your DC. That means if you have a higher score, the patient would have more of these cells, and these cells would be sitting on the nerve. So we published this work also in the BMI journal, and it really correlates very well into the practice. And this is how this whole study was done. So let's look at two patients. A patient one with low SDI, normal T-birth, mybography normal. The other one has all these nerve changes. And what happens to them is, let's assume that both of them undergo, say, LASIK surgery. So what do you expect with this? Because you cut the nerves. So whether you do LASIK, so the nerves are damaged. This is on the 3rd month. The nerves are completely not there. This is just below your epithelium. And slowly this nerve starts growing in the patient one who had a very healthy nerves to begin with. And look at this. This is a very fragile, very skinny, very dull, and absolutely lacks that structure what it was pre-op. So that means that when you operate on somebody who has more of dry eye, who has more of contact lens intolerance, who has more of issues regarding his quality of tears, you always end up with a very poor nerve regeneration. So that's how the biology is. You cut one, it heals slower, and that's when you start getting, and it also affects a lot of factors. Even though you don't see them clinically, this is how the normal keratocytes is. In a dry eye patient with inflammation, you see a lot of white. The white ones are all activated keratocytes. Keratocytes in your cornea are very dormant. They're not activated. They're not in an excited mode. They get excited only if there is a challenge to it. If there's no challenge to it, they're very dormant. You can see the color, they're very grayish, they are hidden, they don't really bother. When they're excited, it means that there's something which is happening. And the patient too, which had a poor nerves on whom we did the surgery, and you can see that this is what happens. The healing at the stromal interface, this is where the laser was given. At 1 year also, you see that it's still not healthy. See, it may not really affect the quality of vision. We don't really know how much it affects. Clinically, you don't see them at all because these are all confocal. The resolutions are extremely small to pick up, even with the best of confocal microscopy. So clinically, you will see as the same. So you would wonder, it doesn't matter. But I just wanted to bring it up that your healing depends a lot on any surgery, whether you do a cross-linking, whether you do a LASIK, whether you do a smile, on how is the status of your eye as far as your dry eye is concerned. So all this is very important in our understanding. For example, you do a PRK and you get a lot of haze, or you do a LASIK and you see an interface haze, or you see a lot of inflammation. It means that there was something wrong in that patient. It means that it's not something wrong with the LASIK machine. It's not that mitomycin did not work. Just means there is something wrong which you need to understand. There are a lot of new tools now, which I'm very happy to bring it up, which looks at a lot of these factors. For example, a new OCT called M39, which just classifies the maps into multiple things. It looks at your epithelium, it looks at your anterior elevation, and it virtually takes out the epithelium and gives you only the stromal epithelium. For example, this patient was referred to me as keratoconus patient, but it looked very keratoconic, but when you looked at it, it was issue with the epithelium, which is creating that band out there. And the stroma, without the epithelium on the last map here, you can see it was absolutely green, which means there was no elevation at all, which just means that it was just an epithelial thing which was creating a mess. And this gentleman had a microneuroma at the same spot here, so which was creating some kind of an epithelial change. So that means that there is tremendous amount of things which are happening, which we no. And this is how what happens when you have an extremely bad healing. A perfect healing, this is the same patient. The storyline exactly starts off with the same patient, with the same nerves, same Meibomian gland dropouts. We did the surgery. So it's like a whole, it's like a parallel story going. So what happens to him afterwards? He's unhappy because he's still having a little bit of residue. Now, should I lift the flap and do it? If you really look at him, he's got a lot of coma out here. because of the changes. And the worst part is everything is coming from your epithelium. That means the laser, what was given to him was perfect. It hit the laser correct. There was no changes here. Is well centered, but you can see some changes happening out here. That was because the epithelium was playing the devil here. The epithelium is playing the devil. If I rewind the whole story back, it's because he had a poor ocular surface, poor nerves, epithelium was stressed because the nerves were inflamed.
Here.
Hello.
Hello.
आपकी आवाज कट रही है. This is checking. Don't do.
We are ready?
Yeah, now I think we can.
नहीं.
Okay, sorry for that.
Yeah, there was a. Can you hear us, Rohit, now?
Yes, ma'am, it's perfect.
Okay.
So the third part is what we should know. So what we should really know, I gave you a prelude into the lot of factors which we probably ignore or we don't know sometimes. And we just touched upon 1% of it. The most important thing is all our current diagnostics and treatments are not good enough. So let's critically and in a very ethical way look at what are the modern treatments which are available to us. One of the treatments is the LipiFlow, which looks at the working on the glands. It gives you a massage on the glands through heat, and we will have a live demo of this at some point of time. So what happens is it's basically works on the lipid components of it. And the indications are when you don't have a dropouts and you're very sure there's no inflammation, when the lid signs like this and the patient has a high OSDI score. The relative indications, very, very doubtful whether it really works on aqueous deficient dry eye because it doesn't really take care of a lot of inflammatory mediators. When you have a huge dropouts, I don't think it really works. And autoimmune diseases, I mean, it's a procedure where you have to really take a call on this. This is a small video I'm just going to play on how it is done. My colleague, Dr. Pooja, will explain how it's done in real time in the live procedure. These are all the signs of the gland changes. And this is a screen which you're going to see once you feed in the data of patient. And after all this is done, you have these connectors. You can do both eyes at the same time. You just place it in nicely. That cup covers the cornea, so it's not going to be affected by the heat. The heat is around 40 degrees, 42 degrees. It gives heat and it creates a pressure. So patient feels that pressure. It doesn't feel heat or anything. It just feels that pressure all the time. So it just feels that something is being taken out. So these are the lipid layers pre-op and post-op. You can see the colors coming immediately. And you can see the change. The good thing about LipiView is you can immediately know what is happening. And these are all some of those changes here. Coming to the light-based therapies, there are two light-based therapies in the market. One is the eye light. Again, it whole concept is that it indirectly, it's taken from the dermatology component, where you indirectly using a very, it's a very nice concept of crystal-based, heat on the cheeks, and you have 5 points there. You can stimulate the Meibomian glands, and you can see these are all the scale what you can do based on the patient's color scale and also the Meibomian gland. So basically, it is titrated to a lot of these factors, and it's pretty quick. You don't need a gel. You don't need a gel because they use some crystal technologies which actually uses cooling. This is a new concept called LTT. It's where, it's a eyelid stimulation because it has to work, light modulation has to work on the upper lids. The concept of light modulation is photobiomodulation, is using the infrared light. It gives you a thermal changes. Basically, it tries to work around the Meibomian glands, those red light with those masks for 15-20 minutes. What it does is it changes the composition of meibum. How does this therapy work? The whole therapy works by the many mechanism. One of the known mechanism is by heat, and heat absorbed by hemoglobin, and hemoglobin working on the blood vessels, and the blood vessels trying to coagulate or change the meibum secretions. This is one of the ways of. There are the other technologies called the EI. It's a French company. There are a lot of similarities, but are also dissimilarities also. The energy levels are different here. It gives you a lot of those validation. Again, you use the skin color. But here you have to use it at the 1 day, the 15th day, and the 45 days. There are 3 treatment is mandatory. And once you charge it, here the whole idea is it works through stimulation of parasympathetic nerve, and you need a gel here. The jelly is necessary because this gives at the zygomatic region. The concept here is a very nice pathway of how the zygomatic nerves using the sympathetic route and then to the geniculate ganglion. You can see that white light flying through and through the pterygopalatine ganglion, you stimulate those slits. So when you stimulate those slits, what happens is you're actually secreting those changes. The glands, the nerve stimulates those Meibomian glands. Once the nerve stimulates Meibomian glands, they come out. So it's very interesting how each company is bringing out their own new technological advances in how treatment works. The big question asked is it really hype or it works? Or many times people have said that this is just a placebo, because sometimes when you bring in a new concept, it looks like a placebo. How do you judge the outcomes? There are different ways of judging the outcomes: TBUT, functional glands, molecular markers. TBUT and functional glands are difficult because many times the glands don't change, and TBUT sometimes also don't change. So does it mean that it's not working? So we thought we'll mix all the 3 and call it the denominators of success. I used it at 3 years. I worked on LipiFlow for last 9 years. So I thought that we'll use it as a 3-year study of what was happening. One thing definitely changes is the OSDI. The patient's symptoms drastically reduces in majority of time. There's a change in TBUT on 1-2 folds higher. But this is very important for me, that they become comfortable. And this is significant number of people become comfortable. You don't see a change in the glands. If you're using change in the glands as your denominator of success, I think you will be in for a not so happy, you'll not be very happy about it, because it does not really change, because glands cannot change. You can get better because your inflammation can get down. But what was very important is why are some people very happy with it, even in spite of not having any changes on your metrics? So metrics don't change, the people were happy. So in life, if you have a perfect machine, a perfect surgeon, and a perfect patient, you also need to have a perfect biology. A perfect biology is the one which heals you. And our understanding is as complex as this because we sometimes ignore biology. We only concentrate around these three factors: machine, surgeon, and patient. Everything of us revolves around these three things. But so we thought, let's forget about these three pillars, the components of our good outcome, and let's just go to the biology because that will teach us a lot. So we started collecting tears from people before undergoing LipiFlow, and they were not, and post-operatively, over 6 months, 8 months over time. And some people did undergo refractive surgery also. So for the tears to tell a tale, it has to go through a lot of storylines. It has to go through a lot of process. And I don't want to go into this, but these tells us what is really happening. And we had 4 groups of patients. Group 1 was the best. I'll come to the group 1. They were patients where everything got better. Their nociceptives got better. There were no inflammatory markers. The tears did well. So you're very happy. The group 2 is what is very confusing, that improved in the symptoms. That means the symptoms got better, but their metrics of tear film still did not change. But patients were happy. So if you're looking at this, 60 to 80% of them were happy with not having much changes. This 20% is always a challenge because they come and you are not smiling, but the patient is smiling. But ultimately, I think the best way to evaluate a technology is the patient smile rather than you having a metrics not coming to you. For example, if you do a cataract surgery and your cataract surgery patient with 618 is happy and you are not happy because he's not reading 6.6, I think you should just feel happy because it's the patient who judges the whole outcome. And if the patient is happy, I'm happy. So that's how I look at it in all the modern treatment, whether you're doing a LipiFlow, iLight, or EI. Your judgment is always based on these 4 groups. The group 3 is symptoms and 3, but there's a 50% reduction of everything, but not fully there. That means you're there, but not fully there. So you are, you can do it. You can do a LipiFlow 3 months later. Even in the group 2, you can do a LipiFlow. It's a costly procedure, but you can still give them medical line of treatment. And the group 4 is, the group 4 is the bad group. That's something where you have to consider it as a failure. It's around 8 to 10% are failures. They just don't respond to this. So you know that this is not good enough. So what did it really tell us? I mean, I don't want to go into all the cytokines we studied before. One in red are bad. The one in green are the good ones. So what you see is inflammation reduced because heat, change in the meibum, change in the bacteria, change in the glands, everything changed to reduce these things. So it does change the molecular signature. That is the important point. We're just waiting for 6 more months of follow-up, and then we're going to write it up, and we're going to publish this paper. So what really happens is these are all the bad ones out there. Some are good, some are bad. So in the group 1, everything gets reduced. Group 1 is everything is happy. Group 2, the ones which are causing your irritation and pain gets better, but some of the factors which are necessary to change the tear film is still, the process is still ongoing. The group 3, too much of inflammation there, just one treatment just will not work. This is where you have to go for the full line, maybe 3 months later, or continue the medical lines. Group flow is the unfortunate one. I think it's not working. There's no point trying it because you have to find some other means to go for it. So this is what really happens. You can see the confocal microscopy, lots of dendritic cells. After 6 months, you can see that the complete loss, all the cells, all the inflammatory cells have gone. Your lipid layers have got better. The patient's OSDI has got better. Is the scatter of tear film, which controls how your lipid layer is helping to see well. This is just your point spread function of your tear film. This was better. The scatter is gone, and your inflammation is completely reduced. So this is a perfect case. This is what happens in around 60-65%. And the second group is absolutely no improvement. The inflammation remains the same. Absolutely no change in your confocal microscopy. No change in your lipid layer. No change in your T-buds. No change in your scatter. more or less the same, or sometimes it may get worse, and hardly no change in your inflammation, because this band shows that the inflammation was just, and these are your 12% of your group, which just doesn't get through. So there's no point trying to push them because they reach the dead end of it. You can have to switch the modalities. So what are the applications of this? How do you move forward with this? We know the background of dry eye. We know that there's so many other factors which are involved in this, which can make your treatment successful. We have looked at the modalities of new modalities of diagnostics like LipiView and the Meibographies. We looked at the outcomes. When you do an outcome, you have only 4 outcomes: the good, the okay, just okay, and absolutely poor. So we started looking at using this as a preventive measure. When I put this up as a preventive measure, the first thing is it's an overkill. You don't need to treat dry eye in any refractive cataract, glaucoma. You don't need to worry about it, because after surgery, patients just will figure it out themselves. This is something which I hear quite often, because it's an overkill to do anything. So this was one of our studies, which is ongoing study. So I'm just giving you a little brief into this. You can see that I showed you good nerves. This is some not so good. And you do a cataract or a LASIK on them. I call it the tsunami effect. It's already brewing there. You make an incision, you make a cut, the entire tsunami of inflammation comes into the picture. What really happens to the thing is that changes everything. The nerves don't heal, the epithelium don't heal well, the outcomes are bad. You end up with having haze, dry eye, they come back to you, pain, and you imagine you have put the best of lens. Like I remember that slide, what I just said, the best patient, the best machine, and the best surgeon don't make the biology to become best. Biology works on a completely different mechanism. It just doesn't care for all of you. You may have got the best of best, costliest LASIK machine, but if your biology is not good, it's gone. Your skill is of no value if your body doesn't react to a response the way it should be. So what do you do after this? You start putting drops. You start giving steroids. So what really happens is you have created a tsunami. It's already there. The minute you've created a tsunami, the drops is not going to work. And that's where the biggest challenge is, because you cannot control the tsunami. So what are the red flags of this? We all know contact lens intolerance, staining, T-butt-less, Gland loss, and all this becomes a most important part of it. So this is the reason, if you have a dry eye today, and if you're operating on a patient, a toric lens, a multifocal lens, a premium lens, a fussy patient, or you're operating on LASIK, it's time you take care of this. If you don't take care of it, it's not going to work. There are multiple methods, drops, medications, and all these new treatments which can really help, and you make them come back to normalcy, and then you can do the surgery. And so how do you connect dots? These are final few slides from my side. This is very important for a cataract surgeons today. Many cataract surgeons believe that these factors don't play a role. That's why I put this case. When you have a poor ocular surface, imagine you do a cataract surgery on these patients. They look normal because topography is normal. And look at their epithelium, they're completely irregular. And look at their EKR, what you use for your toric calculators, or you using it for your multifocal lenses. And you do a surgery, say you do your cataract surgery, and patient still is unhappy. Still has a lot of residual astigmatism, still has glare, still complains of problem, because you've created again that tsunami. And that tsunami has made the epithelium to go in for more hypertrophy. More hypertrophic epithelium will have more changes on your entire multifocality or toricity. So it's not going to work. So however good you are with your skill, that will just mess it up. What I'm trying to say is, when you see that these are the indication, if you have access to modern ways of treating, it is best you treat it, get the tsunami back to order, and then probably do any of these surgical procedures. Final 2 slides. It's very important that this is a slide I started with. We had to erase a lot of things which has been hard drilled in our mind. And one of the things which we had to erase out is dry eye is just the diseases of your ocular surface. Dry eye is a disease of your mind. In fact, I always keep saying that most of the dry eye people, I do have a psychological assessment for them. It's important to understand that they have a psychological problem. I don't know whether the dry eye comes first or the mind is playing the devil first, but one of them is really the devil. At the end of it, they act together. This is one of those papers by Annette Galler and group. They were pioneers in neuropathic pain. What she says is there's a strong correlation with a lot of psychological issues. This is a very, very nice paper in ophthalmology. She's also one of the section editors for this. And I strongly believe that maybe in 5 or 8 years down the lane, psychological disease will have one of their ICDs subdivided as a dry eye disease. It is a psychological disease. It's just not purely driven by it. And there are some evidence to it. There is a lot of spinal fluid, cerebral CSF fluid inflammation in depression. And when we correlated it, we did not study the CSF fluid, but when we correlated it, a lot of these markers, what they see in CSF, the same markers are there in the tear film. I strongly believe that an inflammatory mechanism which drives them to have that depression both in their mind could also be in their dry eye status. So I think when you see a patient with dry eye, also remember that they may be going through depression, bipolar disease, schizophrenia. Keep this, and I do refer a lot of my dry eye patients to psychiatrists because I found them, I really figured that many of them are in a state of one of these conditions. This is something which is very important. I'd like to thank my entire team here. It's an ongoing work. A lot of things are still happening. And I just showed you what is just in the process of completion, the work which is in the process of completion. And I thank Namrata ma'am and Dr. Rajesh Sinha for this opportunity. And if there's any questions I can answer, then we move to my colleague, Dr. Pooja will show you a live demonstration of how the LipiFlow is done. Thank you.
Thank you, Rohit, for that very enlightening talk and for giving a completely new and a different perspective to the dry eye disease, which is so dry and yet you made it so lively. And I think a lot of the myths that you had talked about were, were addressed here. And we do have questions from the audience. There are a lot of people who are watching you Facebook Live, a lot of logins that we've had. And people have really appreciated your talk. And the questions are, one of the questions is that what is the role of topical steroids like fluorometholon in dry eye and when can we use it?
If I answer this, the role of steroids is extremely for a short duration. I would not give it for more than 3 weeks just to reduce that inflammation. And then I usually titrate it based on how the ocular surface scoring is. If the score is very high, more than 30, I use steroid for 3 weeks and then start them on cyclosporin drops like a Restasis or cycloimmune. Or if the OSDI is very low, maybe just for 2 weeks and then just give them lubricant drops, hyaluronate-based drops. So the patients, more than the sign, I give a lot of importance to the patient's symptoms. So I think we are treating the symptoms rather than the signs here.
There's another question from Dr. Ritu Arora, and she wants to know, what do you prefer for surface inflammation, cyclosporin or chloroquine, or any preference depending upon the type of case?
Like I said, if the patient, the cyclosporin has an extremely strong effect when a patient complains of, say, photophobia, or patient has more of a nerve-related issue. So if you look at your OSDI score, like I'm going back to the OSDI again, more of discomfort, cyclosporin really helps because cyclosporin is much quicker in action, much faster. So you can give them only for 3 months, I can taper it off. Compared to a cyclosporin, where I would keep it for people who have more of a chronic disease, where you have more of a dysfunctional problem, but not like pain and other things, like more of a very chronic dry feeling. You will or cyclosporin, they call it, is very effective when the symptoms are more acute, more exaggerated, especially when the patient comes to you with more of photophobia and those kind of stuff.
So there are so many formulations which are available for cyclosporin in the market. Some of them are, emulsified, and then they are coming with nanoparticles also. You think it's going to make any difference as far as the penetration of the drug or the action of the drug is concerned?
Absolutely, ma'am. What happens is, if you really look at all the comparison of the original molecules with the standard molecules, most of our molecules, we did test a lot of them in our lab also. Most of those molecules are quite good in the way it's acting. But nanoparticle based ones have a much better, they retain for a longer time, so they're able to act more. But one of the challenges is that many of them also kill the epithelium. So when the patient complains of a lot of pain, it means that it's actually trying to kill the epithelium because of a toxicity in it. So what I prefer is the unim-based ones without preservatives. There are 2 or 3 companies which are making it. I think that is still the best because it is the collateral damage is much lesser.
And 0.05% or 0.1?
0.5% is what we use.
There's another question, and that is, can patients with MGD be taken up for refractive surgeries? Dr. Sandhyarani, sorry.
I did mention about that. See, it's not a contraindication for it, but you have to be very careful. So if you want to take the patient up, you manage it post-operatively. If you have a stronger MGD, that means your epithelium is not going to heal well. And if you have one of these newer technologies, you can even do the procedure after the 2nd month or 3rd month. That's one of the studies where we are doing it after 3rd month in patients who are having a lot more dryness. But in those MGD patients, keeping them on cyclosporin is a must for at least 6 months, because that is probably going to really reduce you're not worried about your dry eye here, you're worried about the healing. And the worst part of healing is the epithelium becoming a rogue epithelium, which kind of mask all your benefits of LASIK.
So would you like to do some preoperative treatment, maybe give treatment for a month or so, and then maybe plan?
Absolutely, sir. Month of treatment. Now you have these masks which you get, which you keep it in the oven for 30 seconds and you put it on, keep them on a doxycycline. Then you pre-treat them with lubricant, or sometimes you can start them on a cyclosporin drops to reduce the inflammation. So, and the best way to see if its inflammation is getting better or not is giving you a scoring. For example, somebody is not happy with your contact lenses and he comes to you and you treat them immediately, and that patient is going to be a disaster for life. I keep telling this to everybody that if somebody wants to get rid of contact lens because he's unhappy, you're creating a tsunami by doing a LASIK. So if you're not happy with your contact lenses, give them that incubation time of a month or month and a half, and then do it. But if your patient can afford and you are having access to, say, LipiFlow or one of these treatments, the best way to do it is treat it. It's quicker. The action becomes very quicker because you're reducing that inflammation suddenly, and then you treat it. So that option is also there.
Rohit, you talked about a lot of these devices which are now available to treat the MGD, like the IPL, the Meibio, the French one that you showed, EI.
Yeah.
So in terms of efficacy, what do you think? I mean, are they similar, or are
Very
they?
much. Very much.
I mean, ultimately they achieve the same goal.
It does.
And vis-a-vis, if you think of our conventional method of doing it, which we used to do manually, so what do you think would be the difference? I mean, I don't think there are any studies which have, compared all of them or have compared some of them together. But
there are, if you go back to literature, you'll get both sides. You'll have to figure out which side of the coin you want to be in. You'll get that some say that it's better than 3 months of giving hot fermentation and other things. Some say that it is not. So there's an ongoing study, fortunate enough to have all the 3 and using it very regularly in all these 3 platforms. Dr. Sharon and her team are doing a very beautiful study on comparing it from all aspects. If you give us by AIOS, I think we should have an answer ready.
Few months. Yeah, few months time you will have an answer ready.
Anything like crossover kind of thing, maybe one device used for once and then maybe crossover
Absolutely.
kind of.
You're very right. I think, I mean, this is something which I was waiting for you. What happens is, say, LipiFlow is, it is one of the, if you really look at it, is one of the complete procedures, not fully complete, but it is there. It gives heat and it irons it. But if there is a technology like, that's the gold ideal one, which I would look at, like an iLight or a EI, where you stimulate the glands and the gland starts making that mebum secreting, and then you do a LipiFlow, then it works much better. In fact, many chronic patients of mine, this is what I do. I use the one of these procedures, give them 2 or 3 days time, and then I do a LipiFlow, and they have worked very well. But of course, there's a huge cost factor, and affordability is a fact. But that would be in a very ideal situation.
What would be the role of course, we didn't talk about it, but what would be the role of punctal plugs in extreme dry eyes on maximal topical therapy?
I'm not a big fan of punctal plugs. The reason being, minute you put a punctal plug, you are bringing in all your inflammatory molecules to just stay there. If you're looking at an evaporative dry eye, very classic evaporative dry eye, when you want them to be there, then it's only there is a role. But if you're looking at something which is inflammatory in nature, where the patient has more symptoms than the signs, then I don't think it really helps. Many times when we have removed the punctal plug, the patient got better because there's no drainage of those inflammation there.
I think I quite agree with you on that. And it forms like a lacrimal, lake where all these inflammatory mediators are sitting, and sometimes even worsens the patient rather than improves it. Then there is another question on any experience with tacrolimus. Now, tacrolimus, we don't give as frequently as we give cyclosporin. What would be your experience on tacrolimus?
I would really give at the dead end of it when we have looked at really bad collagen or secondary, secondary to a collagen vascular or Sjogren's kind of a problem where you use the tacrolimus. The reason it's not something where you just give offline is because we really don't know the long-term changes of tacrolimus on melanocytes. There's been reports about its changes, maybe just some vague murmurs, but when you don't know something about safety, it's best not to use it as a first line for everybody. And now we have ointments which for the eye, but earlier used to have those dermatological ointment which used to sting a lot, which would create more problem. Now, even now I tell them to use it not on inside the eye, but on the lids.
Dr. Virendra Patil wants to know, how do you treat patients with severe dry eye with SPKs or epithelial defects? Any thing that you would like to particularly emphasize on?
See, one is, like I said, it's most important thing is to figure out where is the biology coming from. These patients don't really have a pure ocular disease. You have to treat, that could be a factor in collagen, that could be a factor in some systemic disease. Of course, if you eliminated all of them, many times autologous serum works. Many times the scleral, Boston scleral Prost lens works. We have to really try out multiple options. And these, I don't think we can ever make an algorithm for these kind of patients. These patients has to be treated. Every single bad ocular surface patient is a new patient. And you probably learn a lot from him, and then you cannot apply it to the others also because it's completely new.
So I think we'll take the questions a little bit later. And can we check on the procedure which is being done live?
Absolutely. I think we'll move to the other room. Dr. Pooja is going to do a LipiFlow on one of my staff. A lot of people would know her. She works for a lot of our conferences.
Yeah, we all know her very well. How are you, Chitra?
Hi, Pooja.
Chitra can't hear. She's a...
Okay. Hi, Pooja. How are you? I think they don't have a...
I'm fine.
Okay. So nice to see you. So can we have a demonstration of the LipiFlow?
Yes. So this is here we are going to demonstrate the procedure of LipiFlow, the indications and the other small technicalities Dr. Rohit has nicely covered. So how do we start with the procedure? Before we start with the procedure, we take an informed consent from the patient on whom we are doing the procedure. Only once we have consent from the patients, we should proceed with this procedure. And what we do here is, this is how the LipiFlow looks like. And we enter the patient details here. Once we have entered the patient details here, we click here on how to perform the treatment. So this will take us to the screen where the treatment is going to be performed. And I'll just start. So we do it under sterile condition, as we're going to be having some applicators which are going to go on top of the patient's eye, which are going to lie on the cornea. So we make sure that we maintain the sterile condition, and we always wear gloves before performing the procedure. And this is how the applicator of the procedure looks like. This is made of silicone, and if you see here, it's a concave shape which nicely fits or snugs onto the cornea, and it just protects cornea from the heat which is going to be developed, heat and the pressure. And this is how it is. We just enter the applicators here, and once we snug it on the plugs, the machine starts identifying the license, and it reads the applicator. So this is one I have for the left eye first. So it's reading it. It's said that once the patient is ready, we can fit this applicator on the patient's eye. We always do it under topical anesthesia. We don't do it without that, even though it has a nice silicone cover to protect the cornea. Look up. So whenever we are doing it, we ask the patient to look up, and we apply the applicator here first on the lower lid, look down. When we ask the patient to look down, we pull the upper lid and make sure that the applicator is on the top of the cornea and nicely fitted. And we make sure that the lids are in between the applicator and the plunge which is here. And we secure it with a micropore tape so that it doesn't move away and it doesn't get out of the eye during the procedure. So there are tapes available with LipiFlow. Otherwise, you can use a micropore tape as well. We ask the patient to keep their eyes closed during the procedure. Just that also makes sure that the applicator doesn't come out on its own. So we usually do both the eyes together. The same thing with the other eye. We first activate the applicators, putting it with the plug which is available. And once the machine gives us a green signal, the machine gives us a message here that yes, now you are ready to go ahead and apply the applicator on the patient's eye. Look up now. So first the lower lid, then we ask the patient to look down now. We make sure that the lids are out and in between the applicator. Look up. So once we have made sure that the applicators are nicely snugged on the cornea, we have options of doing one eye each at one time, but we usually do both the eyes according to the patient comfort. So here we just say that continue with both the treatment. We press it. So the procedure has different temperatures and pressures which are given on the top of patient's eye. It starts from minimum, the pressure starts from minimum of 1.5 Pascal units. It goes to a maximum of 5.4 Pascal units, which is shown here. And the temperature starts from the lowest of 38.5 degrees, the body temperature, and it goes to the maximum of 42.5 degree temperature Celsius. The Pressures are basically in three types. There are three scales. One is just a continuous pressure of the lowest of 3 Pascal units. The second is a step ladder increase in the pressures, which starts from the lowest and goes up to 4.5. And the third is a pulsatile one. It's like an oscillation which goes from the minimum to the maximum of 5.4 Pascal units. And the temperature builds over time. And the maximum temperature goes up to 42.5 degrees Celsius. So when we start the procedure, we keep talking to the patient. We explain the same to the patient as well, that this is how you'll feel the pressure, the temperature, and if you have any discomfort, please let us know so that we can pause the treatment in between, and because we have to take care of the patient comfort as well. So ma'am, this is how the procedure is done. In between, it takes the total time of the procedure is around 12 minutes for each eye.
Okay, Pooja, that was a wonderful demonstration of the live LipiFlow treatment, how we go about it. And we thank Chitra for being our subject today for this LipiFlow. And that was very nicely done. Thank you so much, Pooja.
And Pooja, once you complete it after 12 minutes, would you like to do a little bit of massage of it as well?
So it's a very good question. On the same day, we don't do anything, sir, but I think Dr. Rohit also mentioned that we give this mask to our patients. It's a very simple and dry masks, and it is an Indian-based company only. We just have to put this dry mask in microwave, and depending on the temperature you want, you heat it off around 5 minutes or 10 minutes. The guidelines are given on the box, and we give this to our patients post treatment. So it helps them a lot, and like they're really happy.
So yeah, so you're basically combining both of them together, the LipiFlow and this manual technique. Okay. Thank you, Pooja. Thank you so much.
Thanks a lot.
Thank you, sir.
For demonstrating it so beautifully.
Thank you, thank you, sir.
Thank you, Pooja.
Can
we come back to where Dr. Rohit is now on the...
Yeah.
So Rohit, that was an excellent demonstration that Pooja did. And we have some more questions for you.
Yeah, sure.
So I think Dr. Pallavi wants to know whether omega-3 fatty acids have any role in MGD. Do you normally give them, or you defer them, or is more so the DREAMS trial has come and it says that, omega fatty acid doesn't have a role for the dry eye. What is your take on that?
It's a little confusing because initially a lot of studies did show that it works, and then one trial came, and there's one of these recent journals which says it doesn't work. Personally, I'm still giving it. I believe that if it's not working on the eye, somewhere in the body it's working, because as long as it's causing no harm to the patient, everything works somewhere or the other. That's how a biologist would think. If it's working some part of a body, it's good for the body, so so be it.
As far as it does no harm, so I think we all tend to give it anecdotally, although the DREAMS trial tells us otherwise. And again, there's another question. But
in fact, just to complete that, in fact, at least it's not one, at least 3 of my patients said that the hair fall has stopped.
Okay.
So they're quite happy that somewhere it worked.
Okay. Then another question is, I think we've talked about this before, and you did, touch upon it. What is the role of vitamin D or vitamin A supplementation in dry eye patients orally? Do you normally give it? And if you do, then what is your regimen and for how long?
Not vitamin A, not really, but vitamin D, yes. That's the paper I did mention. Took close to 5 years to get that paper to a stage where it got published in IOVS. It looked at all the factors, what makes a patient in dry eye. It's not that vitamin D causes dry eye. Vitamin D changes how you respond to a particular stimuli. For example, if something is touching me, I don't feel the pain because there's not enough of those receptors, which is making me to say that there's a pain to my brain. So when you have a vitamin D changes in your body, and there are vitamin D receptors in our cornea. And I believe that if God gives something, it means there has to be a function. Because these receptors suddenly starts changing when there is a deficiency. And the same molecules, which otherwise would not cause an irritation, would start making the patient feel a lot more irritated. So vitamin D classically comes with not with dry eye, but comes with a nociceptive problem. Nociceptive problem is vague problems which you can't find an answer to. And when I usually check for this and I find them really low, I usually start. If it's a single digit number, I usually I send them to a physician because they know how to titrate it. Sometimes single digit needs infusion. It's like a bolus dose, like your optic neuropathy. Once you give a bolus dose, the receptors in your eye starts functioning, the vitamin D receptors. And that's how the whole pathophysiology changes. The question comes with, I'm sure you'll also want to ask this question is, everybody is deficient. Why everybody is not suffering from it? The answer to it is, each one of us have a particular genetic makeup where even though you're deficient by say 0, you're still not suffering from that deficiency because your genes protect you from that. But there are people who are unfortunately don't have the genetic makeup where they're deficient by only 10%, but the symptoms are like 100%. So if you want to ask me why only some people suffer, it's because of the genes, what make the vitamin D receptors to behave extremely aggressive. And what genes are this? I mean, that probably will take some time to figure out.
And what is your take on vitamin A, the lubricants which contain vitamin A?
Yeah,
there are some
ointment,
companies
I
which
think,
are, yeah, ointment.
A lot of European market is filled with these kind of amino acid, vitamin types of it. I've been using it in some of my filamentary keratitis thing. I really don't know. Some it works, some it doesn't work, but not something. It's more of purely anecdotal. So just difficult to say.
I do remember that when we had just entered our post-graduation, there were a lot of studies on, role of topical retinoic acid in dry eye and role of topical vitamin A in dry eye, but it really never kicked off the way, it should have, despite several experimental studies and many clinical studies as well.
I feel that it works in some epithelial synthesis. It's got some role in it. So when you see this filaments and when you see this chronicity, sometimes it works because it probably helps in synthesis much more faster and better synthesis.
And what is your take on the duration between the MGD and the refractive surgery and the MGD and phacoemulsification surgery?
If your MGD is, say you have a lot of gland loss, you cannot do anything about it because what is lost is lost. So you will have to do the procedure, but keep them on a longer steroids, maybe doxycycline, cyclosporin, all this maybe 6 months time. But when you have a mild loss of Meibomian glands with a lot of symptoms patient comes with, then I would give at least 3 weeks incubation cooling time before I do a refractive procedure. But I manage them post-operatively for at least 6 months with very strong, I use a lot of cyclosporin because today's dry eye is inflammatory. Just giving antibiotics or this will not help. Today's dry eye needs steroids, which we can't give for 6 months. You need to treat it with something which is non-steroidal or a UV lube like a chloroquine. But phacoemulsification, I think the problem is post-operatively because your microscope light, betadine, paracaine drops, lots of paracaine drops, which is used for topical phacoemulsification. So we have to be very careful to use the amount of topical drop you use in phacoemulsification, sometimes which is unchecked, actually drives a lot of nerve changes because the paracaine has BAK. And this can actually trigger off. It's not your incision which creates a problem. It's what you put on the patient. So when you have a patient with a very chronic MGD or a dry eye, the role of how much paracaine you use should also be measured because that really helps. And then again, keep them on lubricant. These patients do very well with sodium hyaluronate-based lubricants, especially post this. I choose the hyaluronate-based ones and continue with the cyclosporin.
You're talking about cyclosporin, and there's many people, many patients, many of ophthalmologists, they keep asking this question that how long we should use cyclosporin, till what time, months, years, what should be the duration? And this is a question from Dr. S.K. Sharma. He also wants to know that.
If it's not working in 5 months, it's very difficult. It's going to work after 5 months. So for me, the reason I say 5 months is we did earlier, many years back, we did some confocal work about change in the symptoms to the change in your confocal nerves, dendritic cells. So it took at least 4 to 6 months for the cyclosporin to make the inflammation, lower the inflammation on the dendritic cells and nerves. So calling it as a failure, I would call it after 6 months. I know it is because in 3 months, it is only caused 8 to 12% changes if it has to change. To call it as a success, you have to call it after 5 to 6 months. And after 5 to 6 months, if it's working well, I usually give up to around 9 to 10 months and then slowly taper it off. Because by then it has done all its work.
Okay. Dr. Lalit Verma is watching you and he has congratulated you for your excellent presentation.
Thank you, sir.
There are a lot of questions on rebapamide. So we've used rebapamide, and I'm sure you must have also used rebapamide. So when would you like to use rebapamide vis-a-vis other anti-inflammatory, medications?
It works very well when you're looking at a mixed type of dry eye, not purely evaporative. That's where I feel it's used, but I don't get it. We don't get it too often now. It's not something which I commonly get in the pharmacy, but works well also in the filamentary types of disease. The original molecule, what we see in Japan is not the same, I think, what we're getting here. So we're really not sure about it. But I'm not extremely been a very big fan because the molecule which we were getting here used to really cause a patient compliance was very poor. Do you have any different opinion on where you're using this?
Basically, it is a mucomimetic. So we again were using it more for...
Many of these patients whom I have used, they say that, after putting it, initially they feel better, but later on they feel some tightness in the lids, and that was the common complaint by many of the patients I have seen. So I was not very sure whether it is really
working or not.
Yeah.
There's one question, and I think that's a very simple one, and that is, when do you start with the preservative-free tears? So whenever your lubricant frequency is more than 4 times a day, you switch over to, preservative-free preservative-free artificial tears. Then there's one question on what should be the duration for doxycycline in cases of MGD. For how long do you give it, and what is the dose?
Doxycycline works very well when you classically see signs of lid changes. When you see a lot of vascularization during the lids. When you see doxycycline doesn't really work when you don't see a sign. That's what I feel. And when you see a sign, but you just look at the lid margin, you have all that changes, early keratinization, you see those vascularization coming, glands dropping out, then it works well. And the best, I don't know how many people can tolerate it, a lot of them don't, but BD, 100 mg BD for at least 2 months is what is required. At least a month, 90 days is what is the traditional given in the original thing. But what I feel is patients who can't tolerate azithromycin 500 mg, given as every month you give 500 mg for 3 days and for 3 months. That is somewhere, I've read somewhere that it works as well as what doxycycline would do. I don't know whether you tried it. In some of the patients who can't tolerate, because it's a lot of GI upsets with doxycycline, we have tried it, and it's very difficult to find because we use other drugs along with it. It's difficult to say whether it's really worked, but that is one thing which we can try. Have you tried it, both of you, in your practice?
No, I haven't tried
really.
it.
Actually, for MGDs, I mostly use doxycycline, and 1 or 2 studies have shown that 100 milligram once a day or 100 milligram twice a day, they have similar results, they found out. So many times I use 100 milligram once a day, and I have mostly used doxycycline for these cases, not azithromycin.
But to get the perfect benefit, you need 90 days.
Exactly, yeah.
Yeah.
The duration has to be at least 8 to 12 weeks. So the duration is very important.
There's another
And-
question,
Yeah.
which says, how do you compare doxycycline with azithromycin?
Exactly.
Dr. Damanpreet wants to know which is better, and I think we've done
The
that.
study which I quoted, I think was done by Flugfelder. It's a very nice study, and he claimed that azithromycin was more efficacious than doxycycline, and patient compliance was very better. That means 500 mg 5 days, say first month, 500 mg 5 days second month, and 500 mg 5 days the third month. The 3 cycles is what you give, and that would give the same effect of taking doxycycline for 2 months. So that is how it is. The literature, like you said, has got both versions. And other thing where doxycycline really plays a role is if you have that MMP9 kit. And if you have an MMP9 kit and if you do an MMP9 testing and it becomes positive, doxycycline has a huge role. There's an anecdotal story that when they were trying to get the Restasis, which is the cyclosporin in the market, the first thing what they were trying to see is whether they can get a doxycycline drops, because the doxycycline is a very potent MMP9 modulator. So that they could not get a very stabilized doxycycline drops. That's why they went and tried the
Cyclosporin drop.
cyclosporin.
No, there's also regarding this doxycycline drop. I think I can't remember any paper which they have tried experimentally, but I think it would be useful if somehow you can stabilize this drug and convert it into drops. It would be a good idea to use it.
Yeah, it's very difficult because it's very the stabilizing the doxycycline in drops is very difficult. Because it's not, what kind of a mixture you do. So that is one of the reasons they've been not able to do it. But otherwise, it's a very potent inhibitor of MMP9. So more the milligrams you take is able to reach to the ocular surface, and they say through that it's able to work on your MMP9.
And what is your take on inflamma dry? I mean, I think while we are talking about MMP9, we can get over with this also. That it does come out positive for, only when your MMP9 is very high.
Yeah.
But,
see, if your MMP in our body, if you don't have MMP, none of us will be sitting here. We'll all die, because MMP is a healing protein. It is helping you in healing. It's a reparative protein. Every time there has to be a repair, it comes in. Only the excess is sometimes unwanted. So all of us have between 2 and 2 nanogram per microliter or something, if I'm right. 2 to 20 is what is normal, a lot of us. Between 20 to 40 is abnormal. They still have patients do have a lot of problem. But your inflamma dry has a limit of 40. That means if it is 38, it will show as negative. So, but 20 to 30, 39 is also abnormal. So I did meet this doctor who designed this thing, and we are told him that, you should keep it little less. You should keep the offset as 30. Then probably it will pick up much more. So 40 is too much. You will not probably get it. So that's why when you use 1,000 plus rupees in this one, and you try, and if you get negative and a patient is extremely symptomatic, you just get very worried, because the patient may have a 39 nanograms per this one, but it's still called negative because it is not picking up.
So I think it should be used for all those cases where, inflammation is there. Like we used it in a study on ocular SJS patients, and for every single patient, it was positive.
Yeah.
Because, they tend to have high grade of inflammation.
But having that, if you have it, it's a very nice tool to see whether you want to give a doxycycline or not.
Oh yeah, that's what I was coming to. So those patients who were treated with doxycycline did improve over a period of time, but like you said, in that cohort, when we did the DP view, it didn't show any change.
Yeah, it will not change.
Which is expected, because their glands are anyway so bad.
Yeah.
So any other question or comment, Rajesh, you want to ask?
I would just like to say that, I was really impressed, as always, by your talk. And one thing is definitely sure that you see eye as a part of the body, wherein different parts of the body, they affect the eye. Then different, mediators, different aspect, different things, contributing to the health of the eye. And your holistic approach is really, it's really appreciable, mind-blowing, I must say.
And I want to end with this. See, everybody and all the people, including yourself, ma'am, and all the audience are very well versed with how to do all these tests. But one of the major factor which I keep telling now is it is not just the disease of the eye, it's the disease of the mind. If you go back and look at all your dry eye patients who come and take up your chair time, if you look at their mannerisms, their talking, their interpersonal relationship at home, they're not normal. They are suffering. So I keep talking this to psychiatrists that they should really seriously look at a disease where it should be a part of a psychological disease. I'm sure one day in our lifetime it will become a part of a psychological disease, because patients who come to you are not mentally extremely normal, because they do have some stress. They're anxious, they're depressed, they're schizophrenic. And if you really probe in, which is what we do in my study now, I find that all of them need one or the other counseling. But the challenge is, how do you send them when they claim that they're normal? And they always say that it's a dry eye which is causing them to go into a depression. But in fact, depression and dry eye can be together. There could be two arms of, it's like two sides of a same coin, where it could just be a factor. Like I mentioned, the inflammatory and driving dry eye is exactly the inflammation which can drive depression in CSF. So I think that is the biggest take-home point I would like to give the audience, is that be careful, because today we see people committing suicide, people committing a lot of things. You can really pick up all these things just because, and they write in the letter, when they commit suicide, they're dying because of dry eye, because they don't have anything else to blame. And we have to be very careful. We can save somebody's family or life because if we pick this up early. I mean, apart from that, everything else, I think we can keep debating.
Yeah. Thank you so much, Rohit, for your time and for that wonderful live demonstration. And I would like to thank Rajesh also for being here. And also would like to thank Johnson & Johnson for making this happen. And they do it with us almost every other week without any commercial interest or conflict of interest in it. So thank you so much, Rohit. And this was...
I would just like to say one thing. Thanks for changing the perception. Thanks for changing the thinking of people, actually.
Yeah. So thank you. Thank you so much.
Thanks a lot.
Thanks a lot. Over. Imam Shu, happy?
Very happy.